All right, what is up? Good case for you guys today. Single. Let's just actually start it off by. First of all, how you guys doing? You good? Everybody doing well? All right. Good day today. I hope Wednesday. Almost there to the weekend. Hopefully, you guys are getting your stuff done that you need to. Let's talk about case of the day today. Let's turn this down. First of all, what kind of exam was this? What was it? CT, MRI, whatever it was. Let me know. And then what is my rule of thumb for figuring out what kind of exam this is? Some of you may think this is an easy question. Some of you may think this is a hard question. But it's a question nonetheless that you need to ask yourself every single time. Night call, man, that sucks. Night call's not fun. I gotta hit that like wall at like 2, 3 a.m. and nothing helps other than just taking a nap. I just get little power naps in for like 20 minutes at a time. All right, Alex Serrato mentioned CT. How can you tell that this is a CT other than, hey, if you've seen just a bunch of CTs and you just know it's a CT, awesome, right? But how can somebody who's not familiar with CTs tell that this is a CT? I've mentioned this before. My rule of thumb, if you see the bones or the vertebral bodies and they are super white, super white, it's a CT scan. If they are dark and they don't look like teeth enamel, then it's an MRI. So look at how bright this is, right? So we know it's a CT scan. All right, so we're just starting off right off just saying, all right, we got a CT scan here. And then next, as a radiologist, you have to ask yourself, yo, does this have contrast in it or not? Makes a big difference, right? So you got to figure out, is this a contrast opacified examination or is this not? So we look over here. How can we tell, right? We're looking at the vessels. So the vessels have contrast in them. So that's step 2. We know the vessels have contrast in them. This is a contrast opacified exam. So we already knocked 2 things out of the ballpark. 1, it's a CT scan. Number 2, it's contrast enhanced. Number 3, we need to figure out where in the body this actually is. That could be a little tricky if you're not familiar with looking at CT scans and you're not familiar at different types of cut, what things should look like, right? You can use little context clues though, okay? The main context clue that I want you to think about when you're looking at these exams is this vertebral body, the shape of it. What does the shape of this vertebral body? We have 3 different basically types, right? Cervical, thoracic, and then lumbar. So you have to ask yourself, well, is this cervical, is this thoracic, or is this lumbar? What do we know? We know that thoracic vertebra or vertebra have ribs on them, right? So do we see any ribs here? No, we don't. So we ruled that out. Then we're going to go down to the lumbar vertebra, right? So we're like, all right, maybe this is the lumbar vertebra. But if anybody's seen those silly little pictures, right? Lumbar vertebra kind of gives like a hippo or a giraffe look, however they describe it, right? But basically the lumbar vertebra have this big old vertebral body, right? And we don't see that either. So now we're like, all right, well, process of elimination, it's probably a cervical vertebrae, right? So we're like, okay, so now we're in the neck area. Lower head, neck, somewhere around there. So we already knocked off a bunch. We ruled a bunch of things in and a bunch of things out. We know that this is a contrast-enhanced CT of the cervical neck. All right, so we got all that done. Then you got your internal controls. I've talked about this before, right? Remember, this internal control, this density right here is fluid. What does this look like? Well, I don't know. Let's look around right here, right? That's air. So you have air. So you know that this is kind of the level of the mouth, the throat. So we're around that area right here. So a lot of you guys found the abnormality, right? We know it's a contrast opacified exam. So this is the normal side. This is the abnormal side. So you found the abnormality. Good, awesome. But what is the abnormality? So there's kind of a wishy-washy about, I don't know what kind of vessel this is. Is it venous or is it arterial? It makes a big difference, all right? So you're thinking now, well, okay, if it's a carotid artery, I got a couple of answers for that. If it's a carotid artery, that's obviously bad. If you have a carotid artery thrombus, that's going to lead to a stroke, possibly. That's pretty bad. So what I want you to notice is that rule of thumb, veins are bigger than arteries. I'll say that again. Veins are bigger than arteries, all right? So you look on this side, veins are bigger than arteries, okay? And we know that the vein is lateral, the artery is more medial, and right here, vein, and then arteries. So this is your internal jugular vein. This is the carotid artery, all right? So we look over here Obviously, we have a filling defect. I shouldn't say obviously. If if you're new to CT, now you can see what a filling defect looks like. You can kind of see maybe there's some contrast around it. Maybe that's the enhancing lumen, or sorry, the wall of the vessel. But there's something around it that's kind of enhancing, and then there's just a little dot of no enhancement in the middle. So we know that the internal jugular vein on this contrast-enhanced CT scan of the neck is thrombosed. So there's a clot in there, all right? So then you got to figure out, where did this clot come from? And I want to focus on the terminology because there's some confusion as well. What does thrombus mean and what does embolus mean? All right, there's two big differences. Those are terminology that sometimes get tossed around synonymously, but they're not. All right, a thrombus is something that formed in the vessel at that location. So if somebody had a DVT, a deep venous thrombosis, it is a clot that formed in the deep veins of the leg. It hasn't gone anywhere. It's just now there. It's stuck in that big old vein in the leg. What an embolus is now, a portion of that clot popped off, flew up to wherever it did, usually to the lungs, and it caused a pulmonary embolus, or a pulmonary embolism. So that's the big difference between DVT or thrombosis and then embolus. Don't use those synonymously, all right? A lot of people do, but something has to travel from somewhere. You will get a PE study all the time. Everybody's gonna order PE studies. It doesn't matter what age group. Everybody is very cautious about pulmonary emboli, so a lot of PE studies come through our department. And the thing is, if you did, and here's a quick and dirty, if you have an ICU patient that can't handle going down to the CT scanner and like, yo, I think this guy has a PE, I need to figure this out, but the patient's way too unstable, we got to keep him in the unit. Well, what's something else that you can do? Why don't you just grab an ultrasound bedside and go image the veins in the legs, right? Hey, if there's no clot, where's that coming from? Yes, yeah, it could be like in the iliacs, the clot, but it's very rare. Also, don't forget, even if the legs are negative, remember DVTs can still form in the arms as well. All right, so remember, you're looking at the legs, you're looking at the arms as well. And then you got to figure out, hey, which vessels are actually deep veins of the arm. Just remember, for a rule of thumb, or let's just go over them, fine. Brachial, deep vein, all right? What's not, though, that sounds like brachial is basilic. No. Cephalic, no. Cephalic's that awesome little vein that you get on your bicep when you got a nice pump on in the gym. That's a cephalic vein. Those are not deep veins. Basilic, not deep veins. So remember that, please. Next thing I wanted to talk about is a kind of radiology 201, 301 type of question. Is if somebody has a clot in the IJ like this, where could this have come from? If it just formed there, or if it maybe creeped up through other veins starting from the face or the back of the throat. Remember, your tonsillitis patients who have peritonsillar abscesses, remember they can form these abscesses in the tonsils or around the tonsil, and then actual bacteria can go and erode away into the vein, and the vein can get thrombosed. There'll be actual bacteria floating around in there. Radiology 401 question for boards is a board's favorite question. Is some of that bacteria can pop off and go into the lungs and cause these cavitary lesions in the lungs. That's called Lemierre syndrome. All right, remember that, Lemierre syndrome. Just had a talk on this today. We talked about it and went over it. There's a specific bacteria, Radiology 501 for anybody studying for boards. Fusobacterium necrophorum, that's the bacteria that they love talking about. Whatever, regardless. If you see an IJ clot, remember, check for the lungs if it's a septic patient, especially if they have tonsillitis or they have a dental abscess, a carie that turned into an abscess. Remember that, all right? Next thing, what do you do if somebody has an IJ clot? Well, that's kind of worrisome because that clot can't pop off from the neck, go into the heart, and then go into the lung, right? The right IJ is a direct shot straight into the heart, and it's going to go from the right atrium to the right ventricle to the ventricular outflow tract or through the pulmonary artery, and then into the lungs, can cause a PE, right? And that's how the Lemierre syndrome happens as well. So you got to be careful. These patients need to go on anticoagulation for whatever, IR question, all right, interventional radiology. Say the patient can't get anticoagulation. The patient just had some sort of surgery, just had a trauma, has a head bleed. You don't want to give them anticoagulation, right? So what can you do? It's not done commonly, but it can be done because we're IR, right? We can do everything, right? You can place a filter in the SVC, all right? Remember IVC filters, that post that I did a couple days ago? You can place that IVC filter in the SVC. So it's an SVC filter. But remember, In the IVC, it's pointing down like this. In the SVC, it's going to be pointing up like that because it wants to catch the clot from coming up top. So it's going to be pointed like that. So you can drop an SVC filter. All right, it's kind of iffy because that can pop off, that filter, and it can migrate. It's obviously a pain in the butt. And then you need to go retrieve it from there. Any questions that I can answer for you guys? I think this was a nice... what else? What else you guys got? Any questions? Oh, I did have this image. Look at this image right here. This is what I want you to see every single time you're going to place an internal jugular line, a central line. This is the patient's IJ, right? Huge IJ, carotid smaller. You can see the wall of the carotid is really thick. Veins don't have that thick wall, that muscular layer, all right? So this is what you need to see every single time. How can you say, so it was a CT scan, not an X-ray, right? So here's the CT scan. This is what I had pointed out right here. Say you're gonna place a central line, all right? I want you to look at that IJ. Say the patient's IJ is collapsing. They're not that fluid overloaded. They're actually depleted. The IJ may not be nice and plump. What can you do? Put in Trendelenburg, get their head going down, right? And then once their head goes down, it's going to engorge that vein, and then you can go and access it from there. I want you to get really good if you're placing lines to see the tip of your needle within the vein. Learn it the correct way. Please, please, please. Spend extra time to find the tip of your needle inside the vein. Don't just use ultrasound to look at some tissue getting displaced and then you get a flash of blood in your syringe. For anybody who's placed lines knows exactly what I'm talking about. Don't just wait for that flash of blood and go, I'm in a vessel, and then hurry up and thread the wire in there. No, take the time, find the needle in the tip of your vein. Here's a little kind of secret. When I put lines in, I don't have a syringe in the back of my needle. I put the line in or the needle in and I just leave the needle. No air is getting sucked into there. It's not a negative vacuum. Why do they always say, hold on to the wire, hold on to the needle? It's not because it's gonna get sucked into the body. It's because they don't want you to lose the wire in the patient. So remember that. So don't freak out when you finally get that flash of blood. Take your time, find the needle in the IJ. It's gonna save you a hassle when you place an accidental arterial line. That sucks. All right, what else you guys got? Mom 23 Sweeties, hey, appreciate that. Anything else, you guys? Want to pick this up tomorrow, get you another good case. Appreciate y'all. All right, Tiffany, what's up? Until tomorrow, I'll get you guys a case of the day for tomorrow. Once again, remember, that's your thrombosed IJ over there, right? Remember, it's a CT scan, bright, bright, bright. Remember Lemierre syndrome, that can be from the septic emboli that go to the lung. Remember the bacteria. Remember that veins are always bigger than the arteries. Remember to see the damn needle inside the IJ, the actual vessel. All right, that's what ultrasound guidance is for. Let it guide you. All right, guys, I appreciate y'all. We'll do this again as always, all right? Later.